Good afternoon. This is Dr. Bill White again, and I want to pick up where I was a while ago and continue showing some things that happens to the condyle and the disc and what you can do about it. Now, in this particular cadaver, I've been calling them patients. They may have been patients at one time, but these are cadavers or people that donated their body, and I appreciate them. And so that these two gentlemen there in Sweden could cut down their joints and show people exactly, or at least a lot of what can do. We have to remember now that this is they've cut the outer surface off of this where you can see the fossa and the condyle and what they're doing. They won't be exactly like that because this portion has been shaved away, and they took high-speed pictures of this and have shown people what goes on, and you have a better understanding than looking through a small hole at what's going on, or different ways of drawing it once it's not moving. And you could open the jaw and close it and get a pretty good idea of what goes on here. Now, this particular cadaver here, when it was a patient, and now their disc popped off and went in the front of the condyle. Now, this is the condyle, and the jaw is open in this direction, I think. Yes, and this is the disc up here. Now, you'll notice that this thick area on the disc normally has thinned out because this area pops under the condyle, and so the disc gets kind of flattened out and it slips off pretty easy. And if I can here now, I'm going to advance it slowly, and you can see how this disc will do. Now, see, now watch right here. All right, this disc is going to slide off in this direction, and it'll be out in front of the condyle as it opens. And you remember the healthy one has real thick portion back here at the back, and it looks like a big donut. Now it looks like a pancake, or a thick pancake. It's a different shape. And as the person opens their mouth, it'll get to a certain point, and then this will get tight, and this will slip off, but it slips away and tightens this up even more. Now I'm going to see if I can ease it forward again, and sometimes I screw up, and now it's going back up. Now I messed up, so I'll have to go back and play this thing over. So you have to close out here for a minute or more, and I'll have to run through this. Okay, we're back to the point where it works, and now at this point it'll be moving, and you see it, watch it jump, and now it's going to close back, and it'll come off the condyle right up there and slides down in front of it. Now that when it comes off, it makes very little noise. You don't hear it as much as when it pops on. Now when it pops on right here it's going to pop back up on top of there, and that's where you get the click. So you'll be sitting by somebody, and every time they open and close their mouth, it goes, and what's happening, it stretches this ligament out, and it gets real tight, and then it pops back up on there. Now, a person with an early click, sometimes you can correct everything and get it to stay on. Just hold their jaw out front for a while until it develops that thick back part, and don't let it slide off. And sometimes you can get it back on there, but many times you can't, and especially if the mouth opens quite a ways and then it clicks on again. You call it a late click. It's almost impossible to get that click, get that condyle to let the disc come back. Now, Dr. Larry Wolford in Dallas is an excellent oral surgeon, and when he goes in to work on somebody's jaw that needs work and they've got a disc that's coming off like that, he sews the thing back on. What he does is has a staple-like device that he injects into the back of the condyle. It's got two ligaments on it, two threads on it that are tough, and he will go ahead and pull this disc back up on the head of the condyle and sew it down there where it stays, and he has much more success in his work if he gets the disc back on there. Now, some other people in Sweden at one time did some electrical studies of it, and they found out when the disc was off, there was electrical impulses from the body going on all the time when it was off. And people with it off, and even if they have pain in the jaw joint, in the retrodiscal tissue gets to bothering them, they will have pains in their shoulders, they'll have headaches, and they'll have all kinds of pains. And this leads people off that are trying to fight it. And used to, physicians didn't know what it was, and I had a lady once that was a very intelligent lady, and she had this pain in her jaw joint, and she went to all kind of physicians, and they did brain scans and did everything, trying to figure out what was causing her pain, and they couldn't figure it out. And literally, this is what she told me. They were prepared to send her to Terrell down south of Dallas, where there's an asylum that would take care of people. And she was about to go crazy trying to find out what was causing all this pain. And some way or another, she got in the office, and with myself and Dr. Charles Holt really saw the patients with this terrible pains, and we felt of the jaw joint and it was hurting. And if it's bothering you, fix it. And we did, and the pain went away, and the lady lived happily ever after, as far as I know. But she literally had a television program called The Romper Room, and that was always wrong, and nobody could figure out where the pain was coming from. And so working with the temporomandibular joint and solving the problems they have is probably the most gratifying thing you can do in orthodontics, is to get somebody out of pain that's been suffering for months with it, or even years. You know, I've had people be hurting for years, and you move their teeth out of the way so their jaw could come forward, where they have these teeth like this, and you pick them up like that, and their jaw can come forward, and they stop having pain. So it's most interesting, and you need to learn something about it. So I hope I can show you enough here and tell you some experiences that I've had, and it will help you in dealing with the people that you have to deal with. Now watch this. I'm just going to let it go on through here, and you see that come in, and now it's going to pop on. Now it'll click right there. Now it's going to go out, and now it'll come back, and then the patient will close, and there'll be a close and click. Now watch it here. Then boom. There's just a little kind of a thud, like you can listen to it carefully, and usually this thing will go, and then the person can open their mouth more. Now, I'm going to tell you some other things about it here. Right at that point, you get somebody, their jaw gets to this point, they're open just maybe 25 or 30 millimeters, and they should be able to actually open their jaw about that wide without any click or anything. If the jaw is hanging up on a disc that's out in front and it's got a big, this thick area right here out in front and it can't get there, I mean, I've seen people that come like this and they would go to open and they go, that jaw will move to one side, then they click and they will move back, and maybe the other one is off too, and then they go down a little further, and then they click again, and then they can open their jaw straight. In other words, they go like this. And so every dentist and every patient you work on, you ought to examine their jaw joint or examine them before you work on them, so you know what's going on and write it down on your patient record. How far can a person open? What's the space? How far they can move their jaw apart? And it needs to be 40 or 45 or even more millimeters in there. If somebody can't open to say 20 some millimeters, they can't get their mouth open. Maybe both joints have the disc out in front of the condyle, and I had a little girl like that once, and I wrote it down on the record. She could only open 23 millimeters, and I'm sure I told the mother that something was wrong with the disc. It was out in front. She couldn't work, but she forgot all about it, and I started working on the young lady, and I got things limbered up and everything, and she began to open wider than that, and then she was clicking. In other words, the disc popped back up on the head of the condyle, and then she could open her mouth, and it clicked. So the mother came to me. She was all hot in the collar. She said, I brought my daughter in here, and she didn't click, and now she does click. You know, so I had done something wrong. Well, we had got her going better than she was, and now the disc came back upon on the condyle, and she thought it was wrong. But sometimes the disc is better than no disc. I mean, the click is better than no click. But telling them that after they get it going, they don't believe it, or they don't think about it. So she was irritated and thinking that I caused the daughter's jaw to click. Actually, I worked on it and got it doing better, and now she could open it, but the disc, or this portion right here, popped back up on the head of the condyle. So it was so good that I had written it down on the record. So the person ought to be able to open in a straight line, easy. If they go this way, it's hung up over here. If it pops, and then it straightens out and goes the rest of the way, then you've got a problem on this right jaw joint. It can hang over here, and then later hang over here, and then maybe click, click, and then they open. So if you know these things and you see somebody that way, write it down. You get started working on them, and whatever you do, and then somebody gets to paying attention to it, and they want to know why it's doing that, they will actually blame it on what you've done and forget that it's there. You got it down on your record, what they're doing. Now, people that had jaw joint problems, we would take x-rays of them and do these transcranials. Now they've got a lot better x-rays and everything of doing that. So I'm just telling you the experiences that I've had that might help you. So this person right here, this was we got this far, Now it's going to click, and you can watch it, and that makes a click right there somewhere. All right, they have them over there, it did. And now they're going out and open all the way, and they come back again, and now it slips off. Now the noise made when it slides off is kind of a thud. It's not a, the other one gets tight and pops like that. And the disc itself will be flat in the area that's coming off like that. And that is so good to see this. Now here's another person that is broken down further than that. And it's anterior displacement of the disc. Now this one I forget remember, but if the disc stays off, and after a while this ligament, sometimes they open real fast and they'll pull that thing in two, and they get a real hard pain there for a while, and then the condyle stops being round and working in the joint. It'll kind of build out like this. It's kind of like a bird beak, and this will just slide back and forth in there, and that's after they've been off for a long time. I had a lady, and she was popping and giving trouble, and I tried to work on her and do something, and she just disappeared and never did finish up. Well, several years later, I had a record of it there. She came back, and she wasn't having any pain, but when she would open and close her mouth, it was making a shh, 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 kind of a sound like dragging something. And the condyle changes shape. It gets kind of beaked out like this, and the fossil will change too. This will be a flat thing going back and forth, but this normally doesn't hurt anybody, but it makes noise, you know. And the retrodiscal tissues usually not a real problem when it gets out like that. Okay, let's see what this one is. Just looks like it's got the disc pretty well worn out in here, and the head of the condyle is shaping. Now this is sometimes these discs slide to the side, and that's what's doing over here. Now since this is a cadaver that's been trimmed down from the outside, in other words, the capsule was cut off of here, it may not have done that in life, but there are discs that slide to the side, and I think this is what they're going to try to illustrate here. Some of them do that. Other one we saw did to some extent, slid over to the side as they opened up wider, then the disc would slip to the side. And in life, you can kind of tell that, and we've got such good x-rays now that can tell. Now see, the disc is slipping off and going toward the center, and now it'll slip back out as they open the mouth again. Yes, I think that's the way, yeah, it comes back over to some extent in here. Now that pops back in, yeah. Now this is another one, the jaw's opening to the right here, and looks like there's just no disc at all in there. Well, there's something here. Now this one really slips off to the side, and as they open up, it'll pop back over to here, and now when they close, it'll slip off to the side. So there's all kinds of things that happen in here. Some of them cause a lot of pain, and some of them don't. And the retrodiscal tissue, though, if you go back, it's back here, and if you go back and press on that, and it's highly vascular and a lot of nerve endings too, if it gets inflamed and sore, you can't hardly touch it. I've had mine hurt, and if I abuse the one, my right ear over here, it's not totally good, but here I am almost 92, and my joints are smooth and open is good. So they have to heal up and take care of themselves. And so the portion that takes the force right in here, there's so much force. If you bite with your front teeth at all, now when you bite on your molars, it doesn't press the disc near as hard. And you bite back like this, the force goes up the jaw this way. But if you slide your jaw forward, there's no contact to any of the teeth, so the contact is here and here. And if you bite down with, as I said before, you bite down with 10 pounds out here, it may be 25 or 30 pounds back here, because the muscle is back here. And it has to pull harder to get more out here, and the jaw joint takes more pain than the anterior part of the mouth where you're actually biting something. And so if you think about that, when you talk with somebody, you sit down with someone and talk with them about what is causing this. When did it start? How did it go? How did it get there? And how long? You get one that's been there for a long time, then there's something continually happening in there. And you've got to get rid of the cause. I don't give a third what kind of salve you rub on it and how you treat it and do all this other stuff. It'll still hurt. Now, there are people who do things to their jaw joint that makes it hurt. And those people, you need to talk with them. I went to school with a good friend who became an orthopedic surgeon, and his wife's jaw was hurting, and they really didn't teach them what could be done. So I just asked her, well, what do you do? How do you sit at night and watch TV, or how do you reading or writing or something? So she sat like this and rested her head on her chin and her chin on her arm. And if your teeth are loose in here, you can push your jaw back. If you have to rest your head, don't let the weight of your head be on your condyles. Your head weighs, I don't know, 40 or so pounds, and all that weight is sitting on the jaw joints. Now, if you bite your teeth together and they're locked too, then the force sometimes goes up this way. Now, you can get hit in the jaw playing any kind of sport you think of. I had a niece that got in a basketball game, and somebody came in and with their elbow really whopped her. But it made her jaw, it just messed up the jaw joint in there very bad. So I'm going to go ahead and close this one out right now. Now, man.